Dear friends, let us discuss the prosthetic mitral wall dysfunction. These are the mechanical walls that you will come across: the ball and cage, the single disc, and the double disc or bileaflet. This is how a single disc wall looks on transthoracic echo and on the transesophageal and on the fluoro. There is a single reverberating disc which is closing and opening, guarding the orifice. This is how the double disc or the bi-leaflet mechanical wall looks. There will be two disc reverberations and they are closing like a V. And this is how the fluoro will show the opening angle of both the discs. Remember, in a bi-leaflet wall, there are now three orifices when the wall opens, and the central orifice gives you the highest gradients, which you should be avoiding. These are the bioprosthetic valves, and this is how the bioprosthetic wall looks on the transthoracic and the transesophageal echo, and this is how it looks on the 3D. Remember, you hardly ever need to do a fluoroscopy for a bioprosthetic wall except for valve-in-valve interventions. How do we do the comprehensive evaluation of prosthetic heart wall? First thing, look at the date of surgery. What was the type of the prosthetic wall? What was the size of it? Note the patient's height, weight, body surface area, and BMI. Look at the blood pressure, heart rate, and rhythm. Then check the manufacturer's reference effective orifice area of the valve and what are the expected gradients in the literature. This you will get on the smartphone apps. So when you are looking at the bi-leaflet valve on the echo, take a good zoom view and multiple views to look for the motion of the cusps or the occluders, the disc opening angle, the any mass on it, any clot or pannus on it, whether there is any rocking motion of the entire prosthesis, whether there is any swing ring dehiscence, and whether there are some washing jets, which is a normal phenomenon. Also look at the LV and RV function, LARA size, and other valvular heart disease. So never forget to look at the RV function and PASP. When you are doing a transesophageal echo of the bileaflet wall, these are the pictures that you will get. There will be always some closing volume because of the movement of the blood with the closing discs. And there are certain leakage volumes which are called as washing jets. Now, these jets are through the valve, they are very brief, they have very narrow vena contracta, and they do not project well back into the LA roof. Okay, they are very small jets. Now, when you are doing a T for a bileaflet valve, it is important that you rotate all the way from 0 to 180 degrees to look at the annulus to pick up small paravalvular leaks like this. So also you take a 3D view so that you can look at the plagiated sutures and any dehiscence or paravalvular leak or discontinuity. Then how do you do the Doppler of the bileaflet wall? You look at the E velocity and also look at the peak and mean gradients. Then look at the pressure half time, as you can see here, and compare. And also look at the dop, the, this dimensionless index, which is called as Doppler velocity index, where on the numerator it is the mitral wall velocity time integral, and on the denominator is the LVOT velocity time integral, and that ratio is called as the DVI. Then you would look at the effective orifice area. So how do you look at it? You take the stroke volume by taking up the radius of the LVOT and then multiply it with by pi r square into the LVOT velocity time integral and then divide it by the mitral wall velocity time integral to get the effective orifice area. Like in this patient, it is an Onyx 25 millimeter where the manufacturer's reference EOA is 1.9 plus or minus 1.9. So our area that we have got is 1.6. So the difference is 0.3, which is less than 1 standard deviation. Now the same thing you apply for the 2D bioprosthetic valves. These bioprosthetic valves also look at the leaflet thickening for thrombosis and also look for early calcification. Whenever you look at you have some calcification, it actually rapidly progresses when you follow up these patients. The Doppler, you do the same way. You look at the E velocity, look at the peak and mean gradients, and look at the pressure half time. As you can see, it is 93 here. Now, for a Magna 25 millimeter, the expected gradient is 4 plus or minus 1, and the pressure half time is 67 plus or minus 22. Then look at the Doppler velocity index, and here you get it as a 2. And then you look at the effective orifice area, which is stroke volume divided by mitral VTI, and here we got it as 1.5. And for Magna 25 millimeter, the manufacturer's effective orifice area is 1.8 plus or minus zero point 0.5. So we get a difference of around 0.3, which is less than 2 standard deviation. So these are the normal values of the prosthetic valves. The E velocity should be less than 2.2. The mean gradient should be less than 5 mm of Hg. The pressure half time should be less than 100 milliseconds. The effective orifice area should be well above 1.5 square centimeters. And the DVI should be well below 2.2. Whenever we find a very high gradient across the prosthetic wall, the differentials can be hyperdynamic state like anemia or sepsis or tachycardia. It can be a patient prosthetic mismatch, that is a smaller prosthesis for a very large body surface area patient, or the occlusion of the disc or obstruction of the disc by the clot or a pamus, or a bioprosthetic leaflet calcification and degeneration, the paraprosthetic regurgitation, or technical errors in measurements, or sometimes you are measuring the high central jet in a bileaflet wall. So whenever you have a high gradient, think of all these things. Now this is a patient with a prosthetic heart obstruction because of the clot. Now you don't see that on a transthoracic echo, but you can see a good amount of turbulence there. The E velocity is quite high, 2.6. The mean gradient is 16, and the pressure half time is prolonged to 190. The Doppler velocity index is very high, it is 3.5. Then when you are looking at the effective orifice area, where the stroke volume divided by the mitral wall VPI, you get it 0.72, which is quite low. Now, these are the flow-dependent parameters for PHV obstruction, where the flow should be at least 50 to 90 ml and a heart rate should be between 50 to 80. If the E velocity is about 2.5, mean gradient about 10, or the mean gradient is about 12 on stress echo of this patient, or the mean gradient had increased more than 5 above the post-op baseline level, or if it is increased more than 50% from the the post-op baseline. Now remember, these flow-dependent gradients are affected by the LA and LV function, their compliance, and also the filling pressures. Now there are full flow independent measures, and what are those? Those are the pressure half time. When it goes way above 130 or crosses 200, it is severe obstruction. When the effective orifice area goes below 1.5, the measured effective orifice area is less than the manufacturer's reference EOA, less than 2 standard deviation below that. When you subtract the reference EOA from the measured unit, it is more than 0.35, or if there is a reduction in the measured EOA from the post-op baseline. So that is the importance of having a serial, well-documented echoes. And when the DBI is way above 2.5. Now the caveats are that the Pressure half time is unreliable when there is a first degree AV block and fusion of E and A. The effective orifice area is unreliable when there is a aortic regurgitation or mitral regurgitation, and the DVI is unreliable, especially in presence of aortic regurgitation or atrial fibrillation. Now, the decision to do the transesophageal echo depends. When you get a very high DVI, that means the ratio of mitral VTI divided by the LVOT VTI, it is about 2.3, and followed by your E velocity has gone above 2.2. And in that case, if your pressure half time is way above 100, there is no obstruction. If it is less than 100, there is probably a paravalvular MR. And these are the patients where the yield on the transesophageal echo is very high. So let us look at this same patient of prosthetic wall obstruction with the clot. You can see the clot which has obstructed one leaflet while the second leaflet is moving. And the same thing on the 3D, you can see a blob of clot sitting on the leaflet. Now, this is another patient with a degenerative bioprosthetic. You can see that there is a calcification of the leaflet, there is immobility, there is a regurgitation, and there is a forward turbulence. Now, this patient has got its E velocity 2.3, mean gradient of 9, and the pressure half time has increased to 162. This is the 3D of the degenerated bioprosthetic. You can see immobile and thick leaflets and a very small orifice looking from the LA side. Now, these patients are a good candidate for wall-in-wall procedure, which is a transcatheter procedure, where the T is helpful in taking the interatrial septal puncture, and then you can guide the catheter across the wall, and then can deploy the same transcatheter wall that you use for TAVR, that is the Evolute R, and you can inflate it inside the degenerated prosthesis. And this is how it looks on 3D, where all the three cusps are thin and open well, and no paravalvular leak. And the mitral flow now shows hardly any gradient and a very rapid E deceleration time. So how do we approach the high gradient? If the E velocity is above 1.9 and the mean gradient is above 6, then look at the measured EOA and compare it with the referenced EOA and see whether it has reduced from the last study. If it is reduced, then probably then we need a certain other sets of investigation. If it has not reduced, then again you need certain different way of thinking. Now suppose if it is reduced, if the measured EOA is reduced below the reference EOA, in that case, look at the DVI. If the DVI is increased and the EO is reduced, that means there is an obstruction. In that case, look for the abnormal disc motion on the echo or fluoro like this. Here you can see that one disc is not moving, that is causing the forward turbulence. And on the fluoro, you can see only one disc is moving while the lower disc is fixed. Once you know that the obstruction is related to the abnormal disc motion, then look at the DVI. If the DVI, that is the mitral wall VTI divided by the VTI, is about 2.2 and the pressure half time is prolonged, it is a definite case of a prosthetic heart wall obstruction. However, if there is no abnormal disc but your gradients are high and your pressure half time is low, then probably you are doing some misstep. And it may be that you are overestimating the mitral gradient by taking the central high velocity jet in the bileaflet wall, or you are underestimating the LVOT flow by technical errors. So the thing is, the difference of a pannus and thrombus, which is obstructing the wall, is like this. The pannus is a very small mass, which is very fixed. It is immobile. It centripetally grows. It grows at the inflow of the prosthetic heart wall. While the thrombus is very large, it's hypoechoic. It covers the annular ring and it projects into the LA and also overlying the prosthetic heart wall, and it has got a lot of mobile elements. So this is the clot that we saw. The clot is extending into the ALA. It is sitting on the disc. It is hypoechoic and it's quite globular. While this is a panus in a 9-month amenorrhea patient, which is fixed, it is echogenic, doesn't have any moving components, and it is growing centripetally over the PHV on the prosthetic heart wall. And this is the same patient's wall after expand. You can see the panels growing and obstructing the disc. Other important things are the panels generally come late in the natural history, while the thrombus is more common in the earlier age of prosthetic surgery. Then the location of panels is more on the mitral wall. The thrombus is more common on tricuspid, followed by mitral, and mitral and aortic have the same incidence of thrombus. The other differential is to look at the cardiac CT, where the panels have high Hounsfield units, while thrombus has low Hounsfield units. Now, suppose the major orifice is the same and there is no change. However, the gradients are high. In that case, index the effective orifice area by dividing it by the body surface area. Now, if it is low, if the index effective orifice area is less than 1.2, you are dealing with a patient prosthetic mismatch. That means the patient has received a smaller prosthesis for his body weight or body surface area. So here is a patient where you can see that the body surface area is 1.7 and he has a tissue wall, magna wall, where the reference EOA itself is 1.8. So if you index the reference EOA, it is already less than 1.2. If you look at the bioprosthetic wall closely, the leaflets are moving well. There is not much turbulence there, and the E velocity is 1.5, mean velocity is 5. However, the pressure half time is prolonged. Now, for the same prosthesis, which is not having any degeneration, the DVI is also increased. It is 2.5. So that means this patient with a prolonged PHT and prolonged DVI, there is some obstruction. However, there is no degeneration in the leaflet. The leaflets are moving well. If we look at the effective orifice area and divide it by the body surface area, then what you get is 0.78, which is quite significantly low. Now, for a magna, the 1.8 is the effective orifice area, which is the reference, and what we got was 1.33, and the difference was actually less than 2 standard deviation. But however, when we divided it with the body surface area, we got a very low effective orifice area, telling us that is the case of a patient prosthetic mismatch. So the thing is, at a mitral position in non-obese patients, anything less than 0.9 is a severe PPM. While for obese people, the cutoff is lower and it is 0.75 for severe PPM. Now, the severe PPM is seen in 2 to 10% of patients in mitral position. The PPM diagnosis is by having a normal EOA for the valve. The occluder disc or the leaflets are showing normal mobility. The measured EOA is within 1 standard deviation from the reference EOA. The difference between the reference and the measured is less than 0.25. The DVI may increase and or may be normal. The indexed EOA is actually reduced. It is less than 1.2. The PPM is present very early post-operative. It is there in all the subsequent echoes. Now, the PPMs are associated with worse hemodynamics and worse functional status, worse quality of life, and more structural wall degeneration. Suppose the index EOA is more than 1.2 and still the gradients are higher, but the pressure half time is less than 100. That means this is a patient who has got normal wall structure, but the gradients are higher. The effective orifice area is more than 1.2, but the DVI is high and the pressure half time is very rapid. Now, these can be the cases of either high output or a paravalvular mitral regurgitation. So, how do you suspect an occult prosthetic valve paravalvular leak? If you see a pizza on the LV side, or if you see turbulent color flow in the LA, if the E velocity is above 1.5, if the gradient has increased above 5, the DVR has increased more than 2.2 for mechanical. If the PHT is low despite the DVR being higher, and there is an increasing, progressively increasing pH, the LV looks dilated and hyperkinetic. Think of an occult paraprosthetic MR. Now, this is a patient with a significant paraprosthetic mitral regurgitation. You can see the jet is arising outside the sealing ring, and the E velocity is 2.5, and the pressure half time is way below 60. This is another case where you can see actually there's a discontinuity in the sealing ring, and you can see a large pizza on the LV side and a very large jet going into the LA from the paravalvular leak. And the same patient in three-dimensional AFP shows a large gap at the 11 o'clock position where the aorta is 12 o'clock position. Now, to know that this is not an echo dropout, you should have your color Doppler on, showing you that this is the origin of the paravalvular jet. And this can be very well plugged by the transcatheter devices. Now, severe paraprosthetic MR will have a centric wall hugging jet. PISA will be at PISA of 50 to 60. The circumferential extent will be more than 30%. When it is more than 40%, actually the device starts rocking. The vena contracta width more than 7. The pulmonary vein will show a systolic forward flow blunting or reversal. The CW will be triangular. The effective ring orifice will be more than 40. There will be LV and LA dilatation, and LV will be hyperdynamic. And the last part of the prosthetic wall dysfunction is the infective endocarditis. You may find such large masses which may even obstructing it. But what is more important is to look at the sealing ring very closely for an abscess. So in an infective and suspected infective endocarditis, the sensitivity of TB is very high. You need a serial D investigations, look for the vegetations, look for a new onset of paravalvular leak, which may suggest infective endocarditis in a proper clinical situation. You may have new bioprosthetic valvular regurgitation. You look very carefully for the annular abscesses or for any prosthetic void dehiscence. Thank you.